So first of all, I think that I'd love for you to introduce yourself, let everybody know who you are, what your background is, and we'll jump right in.
Sure thing. My name's Kevin McNamara. I'm a doctor of physical therapy, currently operating out of Johns Hopkins in Baltimore, Maryland. I am going through a sports medicine residency program there. In terms of background, so completed PT school in 2019, so I'm pretty fresh. Um, uh, was down in Arizona with that. Undergraduate was in exercise physiology. I actually kind of really thought that, strength and conditioning was going to be my landing spot. Have experience in sort of the private sector, a little bit at the university setting there. And really, I kind of felt like I was in this position where I either had a little bit of a knowledge gap where I wasn't able to kind of help people to the degree that I wanted, or what would happen is I'd have clients kind of leave, they'd get injured or whatever have you. And they go to rehab for, 12 weeks, whatever it is. And they'd come back and I'd be kind of like, what the hell happened, man? Like, well, what were you doing? So I felt like I could kind of, if I had a little bit more knowledge underneath my belt, a little bit better understanding of some of the specific musculoskeletal stuff, I feel like I would be able to, do what they were experiencing in rehab, but be able to do it better. So really, it came down to I had a passion for strength and conditioning. I had a passion for physiology and musculoskeletal stuff. So it was either going to kind of pursue med school and go that route. Took the MCAT and all that. I actually had a client at the time who was an anesthesiologist that sort of, in a way, talked me out of that. So I think the length of the education was a little bit of a deterrence to me. So kind of looked into physical therapy, and I felt like it was a great way to sort of blend a couple of passions of mine, and that's how I kind of landed where I am.
By the way, how did you find yourself while still studying, right? In clinical athlete and the entire affiliation there, and starting the journal club along with Gwen?
Mm-hmm. How did that come about? Is that what you're asking?
Yeah.
Yeah. So let's see. So I've been a member of clinical athlete probably before I went to PT school, back in the wild, wild west days, like 2015, 2016, where there were some intense discussions going down. And really, I kind of, I thought it's an excellent forum for learning. And that's one of the things that I appreciate most. And these things are getting harder and harder to find, sort of these communities or these areas for long form discussion where you can kind of get into some of the nuance and have an understanding of some of the real details where, now everything is so compressed. There's really no platform for a lot of, lengthy discussion and understanding to come from. So I kind of recognize the real value in that. So I was on the forum, 2015, 2016 throughout PT school. And I really just kind of, I put myself out there. I was there to learn and kind of have discussions, and I was wrong a lot of the time and continue to be wrong. But, I was kind of having communication with Quinn, and I said, I think what would be really valuable, because, one of the things with clinical athlete is we try to utilize the literature as much as we can and remain evidence-based. That's kind of become a little bit of a buzzword now, but I felt like
Definitely.
there was nothing in the market where we could have these discussions regarding pieces of literature and really dive into, what does it mean? How do we kind of interpret some of this stuff? And really, how do we apply this in our day to day? And, kind of looking, at the environment online, I didn't feel like there was really a place for that. So I kind of put forth that idea, and it's been good, man. I think we're, 20 some odd in now. Been going since 2018 or so. And that's kind of how that came about. It just seemed like there was a little bit of there was an opening in the market there, and people seem to be liking it. So that's how that kind of came to fruition.
hmm It's definitely kind of an old school mentality, the same way that it was with bodybuilding.com before the whole evidence-based community sort of burst out. Uh, all right. So, with that out of the way, I wanted to start talking to you about our subject today, which is movement variability. And as we said before, specifically when it relates to stuff like stability balls, BOSU balls, to correct the problem, quote unquote, problem of ankle instability and the coachability behind it.
Mm-hmm.
Now, I wanted to get my 2 cents in and just let you respond. As I said, I don't see it as a valuable tool. It's strictly because I don't see it as a valuable tool to coach someone through it. I mean, it's like just putting someone with movement problems, put a barbell on his back and just tell him just back squat before he even knows how to either body weight squat or goblet squat. And there's no real way to coach him through the process. Just let him wiggle around until he sort of finds his balance with no real progression or any plan in mind. So first of all, I wanted to get your takes on that.
Yeah, so if we're talking about sort of like the utilization, let's call it like unstable surface training, right? It's kind of what we're talking about
Yeah.
here, and kind of how does that apply in, in a rehabilitation setting or something like that? Well, I think, if we kind of go into the literature and we look at a lot of this stuff, what we find is unstable surface training, the transference in regards to carryover to kind of day-to-day movements or options or things like that, it's not real great. We find that, balance training in particular is very specific to the task. So by me putting someone on an unstable surface, with the idea going into it that, this is somehow going to improve their ability to stabilize after an ankle sprain or something like that, we don't see a lot of great carryover to that. What we find is that the person gets better, stabilizing on a BOSU ball or on a foam pad or whatever have you. But in terms of the idea that it transfers over to, a sporting environment where, the environment is very different. The sort of chaos is there. I don't think I would agree with you in saying that it doesn't make a lot of sense to me in terms of, we're trying to manipulate this environment to where we're hoping to replicate what they may see in a sporting demands, but that's just not the case. The person gets better at balancing on the BOSU ball, but it doesn't really improve their ability sort of to absorb or accept force, in a sporting, sense, let's say. So to me, unstable surface training, if we're coming at it from the perspective of we're trying to do this to recreate sporting demands or the chaos of sport or what have you, I think it really falls short in that sense, simply because, the task fidelity, if you will, is really not there. We see that the person may become excellent at balancing on an unstable surface, but it really does not hold up to the demands that they're going to be experiencing in their sport. So if that's the goal behind it, to me, I think that we need to try and get as, specific as we can. Obviously, we're not going to be able to really do anything that is sporting specific, but at the very least, we could probably try and maintain some sort of stability in regards to playing surfaces. So to me, I don't find a lot of value in utilizing an unstable surface if that's kind of the way that we're approaching it.
And what if we're approaching it really from sort of an aspect of teaching as many positions as we can? Because obviously, when we're in a different setting that's a bit more constrained, whether it be lunges, squatting, or your quote unquote typical strength training, obviously, you're also not replicating the positions that are also going to be on the field. So, how do we go about bridging these two complete opposites of the spectrum?
Yeah. So to me, it kind of comes down to what qualities are we trying to develop, right? So if we're looking to maximize things like force production, we know that utilization of an unstable surface is going to negatively affect that to me. So if I'm looking to sort of bridge the gap, if I'm understanding your question correctly, in terms of how do we sort of merge the worlds of strength training and exposure to different patterns or, you know, movement variability, is that kind of what you're getting at?
Yeah.
I don't think that an unstable surface is a good way to sort of bridge that gap, to kind of use your phrasing right there. To me, I would say, let's take a look at what we're doing programming wise. You know, are we involving multiple planes, you know, sagittal, frontal, transverse? That's the way that I think that we should go about and try in terms of trying to enhance movement variability. Because really what we're talking about is sort of the range of options that the system has, you know, the ability to access, right? Or the way that they're maybe organizing movement patterns to complete the goal task. So it's really the amount of movement options that are accessible to that person. And I don't think that there is really any sort of utility for an unstable surface in doing that, simply because they're not playing their sport on an unstable surface, right? So to me, I don't find a lot of value in utilizing it for that sense.
Now, usually we also see it utilized in physical therapy or a rehab setting for injured people under the claim that it helps you strengthen the muscles that you don't usually strengthen during conventional training, and helps you with proprioception and all sorts of wild claims. I've even heard it works the deep muscles of the abdominals more than it.
Yeah.
I think that we've heard enough of that. But do you think there's any value to it in a rehab program?
So I think we can say, like, right off the gate, this idea that utilizing an unstable surface is targeting, you know, specific musculature that you're not going to get. I think we can throw that out the window right away. To me, we're not really doing that there. It's not to say that they don't have value, but I would say, you know, particularly if we're talking about things like, let's say, you know, concussion or something like that, where we're trying to manipulate the systems that we're kind of using to create, you know, proprioceptive awareness or an understanding of where we are in space. I think for that it can be valuable. You know, we talk about things like, you know, the best test or things like that, where we're trying to remove proprioceptive input to the system to kind of target, you know, the vestibular system or the visual system or things like that. So I think if we're using it in that sense, it's still valuable. But in terms of using it as a modality to, um, you know, specifically target certain musculature, nah, man, I don't see that at all. I think it's a myth that needs to die. So that's kind of where I'm at with that there.
All right. I think that usually when people talk about it, there's a big sort of law of diminishing returns there, where they want to work on a lot of different qualities, whether it be movement qualities or just basic skills that they want to improve, where they just spread out to places that aren't completely unspecific to them. If we go again with the example of the unstable surfaces, they go to that right before they go to some even unilateral work like single leg deadlifts or even something like a skater squat. Uh, and I think we can see that in a lot of strength training methodologies, that they just want to focus on too broad of a spectrum. Do you think that there's sort of a place where we can be too specific for our own good as well?
Okay, so I think, you know, if we think about this in terms of, you know, can we be too specific? I think it largely depends on the context that we're talking about, right? So an example of this might be if we're dealing with someone in a rehabilitation setting, there's going to be certain benchmarks or things that we need to address first before we can kind of move down the line, right, through the later stages of rehabilitation. So that's where I think having a good approach to a needs analysis and an understanding of, what are the constraints of this individual that are maybe limiting their movement options. That's the time to me where I think we need to get specific. Now, if we've already established that they have these qualities, right? Maybe they've normalized range of motion. Their ability to produce force is, at a point where we deem it, sufficient enough. That's an instance where maybe if we continue to sort of program or design, interventions to continue to target those things, even though they've relatively been sort of normalized, or they're no longer a constraint of that individual, that's when I would say that maybe we're being too specific. But it probably comes down to what's kind of the goal with the intervention for us. Because if we're looking to do, sports specific training, we need to kind of make a concession right away that really everything that we do in the gym is not going to have a certain amount of specificity. Like it's never going to be truly representative or specific of the sport that they're engaging in. We utilize places like the gym and the rehabilitation setting to identify and target the constraints or the limiters of the person, with the hope then that if we are able to influence those, it then opens up a larger range of options for that person to access. But I think the idea that we're going to use this intervention because it is specific to their sport is misguided.
Mm-hmm. Okay. Now I want to kind of bring you back to the point where you weirdly enough introduced yourself when you were talking about the fact that you lack the knowledge to address people's injuries when you were training them. And I wanted to talk to you about the importance of um, of that population to start training, and people like the elderly or people who have been injured and are going back to your services as a coach. Uh, Most of the time we see either doctors or even PTs prescribing them with training modalities that to us seem kind of strange, like the stability balls, like the band work, and they just simply don't allow them to strength train.
Mm-hmm.
So I wanted to hear your thoughts about what do you think about whether or not it's important for them to go right back into strength training, and how should they approach it?
Yeah, so I'll be honest with you, man. So like my kind of approach to treatment is really, if we think about kind of like rehabilitation and general strength and conditioning, I think that they lie on the same spectrum. The only difference may be in kind of where that person, what their baseline is, right? So if we think about, I think about rehabilitation as maybe it's a little bit more, can be maybe more tissue specific. We're looking to maximize a local envelope of function. But we're also, at least certainly with my approach, is I'm trying to maintain baseline fitness characteristics in the presence of, maybe pain, maybe something that is postoperatively where there's an insult to tissue integrity. But I think at some point, the interventions that we're utilizing, they should be pretty much the same. The only thing that we're really going to change is maybe the distribution of programming. Like I said, it may be a little bit more, local envelope of function specific or tissue specific.
Mm-hmm.
That to me is the real kind of delineation between rehabilitation and training. The interventions are largely the same, but it's more so what is this person's load tolerance that is kind of the primary differentiating factor. Whereas in a rehabilitation setting, maybe we're dealing with a person, whether it's because of pain, whether it's post-operative, whatever it may be, we may have more of a tolerance issue that we're kind of dealing with first, right? Whereas in the strength and conditioning side of things, we're not really too worried about tolerance. It's more just finding a right dosage for that. And I think that they're the same in that sense, in that we're always trying to figure out, what's the appropriate dose to get the adaptation that we're working for. There just may be other factors in the rehabilitation setting, whether it's pain, whether it's, biological, tissue healing timeframes that are really, really different. But I don't think that the interventions should be all that different. if that makes a sense. Does that kind of answer your question?
Yeah, definitely. Now I want to to go further down that rabbit hole and ask you about the progression of programming. When you mention that we need to figure out a load they can uh, do a certain exercise in without pain or discomfort, do you look at other things as a progression modality, such as maybe reducing constraints if you're letting them do a box squat the next week, let them try to do a shallow normal squat without anything to sit on, or even slowly increasing moment arms. I think that one of the things that I liked the most that Quinn was saying at one of his podcasts is less about load management and more about stressor management, alluding to stuff like when we look at landmine presses for people who have pain whenever they're going into shoulder flexion and slowly increasing that range of motion under load, not necessarily the load itself, but the actual range.
Yeah, absolutely. I would very much echo that right there. I really think maybe that's even a better kind of representation of maybe the differences between rehabilitation and training is, the constraints of the individual, right? So if I have somebody that is, maybe painful with terminal knee extension, right? Because they have, some sort of nebulous, patellofemoral pain or something like that. Can we possibly constrain the environment to where we're looking to, let's say, target, the extensor mechanism, right, or the quadriceps, right? So in a rehabilitation setting, this might be something where, okay, for whatever reason, their patellofemoral joint is not tolerating some of the load or the compressive forces at terminal knee extension right now. Just the envelope of function is not quite there. They're a little bit sensitive to that. So how can we sort of constrain the movement to where I'm still driving load and stress through the extensor mechanism, kind of targeting a quadriceps deficit if we have one? That's an indication where we're manipulating just range of motion. So instead of going, 90 to 0, where they get sort of symptomatic at terminal knee extension, all right, maybe we're going, 90 to 20 or 90 to 30, whatever it may be. And then we're just slowly kind of bumping up that range of motion to the point where graded exposure, we've reached a point where the patella is less sensitive to that terminal knee extension. And then we go for, full range of motion, whatever it may be. So I think identifying, what are the triggers or, what mechanical sensitivity is this person dealing with is probably where rehabilitation really lies. Because to me, it looks the same. I think good rehabilitation is just training in the midst of, a pain experience or tissue sensitivity. So how can I sort of constrain the individual to where I'm still getting the desired fitness adaptations that I want, but maybe just the only, like, the wild card is the person has pain with it, right? So your example of a box squat's a great one, right? So maybe, someone has pain with deep hip flexion, right? So we're just constraining the range of motion to the point where I'm able to train the squat pattern or the knee dominant pattern that I want, but we're just manipulating variables, whether it's load, whether it's range of motion, whatever it may be, to kind of meet them where they are and continue to drive those adaptations. So I think that's an excellent way to put it, is maybe we're manipulating, lever arms, things like that. For shoulder flexion, are we starting with a long lever arm? Well, maybe not. Maybe they have an irritated, biceps tendon or whatever it may be, and we're just slowly progressing to where the demands increase through the tissue, through the joint, whatever it may be.
And do you think that's something that we can learn and utilize in conventional strength training? Because I see that a lot of people are talking about it, the importance of load management, but I also notice it's somewhat becoming of a buzzword, much like mobility and stability have become recently. And they just think volume, load, instead of thinking about the big picture.
Yeah, absolutely. So it may not be, it may not be a load management issue at all, right? It might just be that for whatever reason, this person is sensitive to a certain range of motion, right? So as much as I wish it was, and and I love Tim Gavitt's work, I wish that acute to chronic workload ratios and load management were kind of like the panacea of it all. But unfortunately, I don't think that's the case, and we can probably get into trouble in both ways, right? Being overly focused on managing load. In some cases, that is the case where this person is just doing too much too soon after too little for too long, and they become symptomatic. But I think we probably go wrong if we think that that is the only factor that is contributing to the irritation or the sensitivity that this person might have. So maybe it's not a matter of they did too much too soon. Maybe it's just that for whatever reason, they're only able to tolerate deep hip flexion so much. So perhaps it's not the fact that they did too much hip flexion. Maybe it's that the range of motion needs to be constrained in a different manner. So I think I like what you said there in terms of we can't get too hyper focused on the discussion of load management, because there may be other variables at play that are contributing to some of the things that this person is presenting with.
Do you think the psychological factor is also something that we should look at? If I take your example of knee extension, if I take someone and try to do something like a reverse Nordic with him, and he experiences immense pain at the beginning of the movement, but then I take him to just a straightforward leg extension machine, and he feels no pain at all.
Yeah, I think so. Psychology is always at play, right? So because that person, they have an experience with whatever motion it may be that, maybe now that they do have this sort of psychological attachment to, every time I do this, I have pain. So this is a hard discussion to have, because I don't know exactly how much that would always be a factor based on the current situation, but it's certainly going to always be there, right? So I think that's an important one to have, even if we're talking about low back pain or something like that, or psychological variables. Maybe that could be the limiter too, right? It may not even be an instance where there is any sort of insult to tissue or anything like that, but it's maybe just this person has that thought process or awareness that, this is a troublesome movement to me. And I think that's where having a discussion on kind of, what this person, what their understanding of what is going on is important. What is their experience with these things in the past? That's where we really need to get into having a discussion on what does this person think is going on? What is their sort of attachment to this motion, or what do they think is going on when they're having that pain experience?
Mm-hmm. And how do you think that we can figure out that that is indeed more psychological than, say, something like tissue damage, when we know that a lot of the times when we send people to do an MRI or an ultrasound, it comes back that they don't actually have anything, but maybe the results don't show what actually goes on inside, and there is indeed tissue damage that we need to address.
Yeah, that's a tough question, man. That's a good one. I think so. Whenever I'm kind of dealing with stuff like this, I always want to have an understanding of kind of, what's the base rate of the stuff that we're dealing with, right? How many people in a population may have some sort of, quote unquote pathological finding on imaging. So I think understanding, what's the base rate of this is important first off to have, because there's plenty of times where, if we take MRI imaging or things like that, we know that there's a lot of people walking around out there that have something on imaging that may be considered pathological, but they're not symptomatic at all. So I think having an understanding of what is the base rate of the condition that you're looking at is a good place to start, because that kind of helps us frame the discussion of how odd is this. If it's seen across populations relatively consistently, and meaning that there's a lot of we call them incidental or finding on imaging that is not necessarily related to or correlated to their pain. It may be, but I think having an understanding of what the base rate is, how long have they been symptomatic, right? So if we're talking about someone who's had an acute injury, like an ankle sprain, it's very swollen, things like that, it's probably more likely that there is some local tissue disruption that's contributing to that, right? But if you have somebody that's coming in and they've had symptoms for, 6 months, a year, or however long have you, that's kind of generally when we shift the needle towards, well, it's less likely that there is, some sort of tissue damage or disruption that is contributing to this. So I think that's kind of the way that I frame it is, what is the base rate of the pathology that they may be reporting that they have, or that is being shown on imaging? How long have they been symptomatic for? That kind of helps me divvy up, okay, is this person dealing with a more nociceptive dominant type of issue where there's local tissue disruption that is contributing to some of the symptoms or the sensations that they're feeling? Or are we dealing with someone who's had this pain for, a year? Yes, they may show some sort of, let's take the hip, for example, some sort of cam or pincer morphology. But is that the reason that they're having pain? I don't know, but I would say that it's probably less likely of a major contributing factor in that sense, as opposed to someone who has, a trauma, an acute injury, there's disruption, we see it on imaging. Yes, okay, this is probably an instance where the local issue may be a larger factor in some of the, the discomfort or the pain that they're experiencing.
Now, at what point would you consider something like a surgery to treat a certain injury, whether it being shown in the imaging? Obviously, we need the imaging to actually decide that it needs to be a surgical process. But I know that usually doctors tend to go to the surgical route very quickly. Uh, Sometimes even before that imaging shows anything. Do you think there's any value to it, or would you wait a while and get the risk that maybe the MRI didn't show something that was happening, and that the surgery would have prevented further damage?
So I think that probably comes down to what sort of injury or what sort of thing we're talking about, right? So um, let's take here's like a good thought experiment is like, what things absolutely need surgical intervention, right? So compound fracture or something like that. Yeah, that person needs to, they need to get that, managed, through the surgical route. I think it's a hard to give a firm answer on that because it is very much specific to, what sort of injury are we talking about? What is the person in front of us? What are the demands that they're looking to, what are their daily demands, right? So if I have somebody who is, let's take an ACL rupture, for example. And even this, there's an area where it's not quite as black and white as we may think. But let's take, for example, so if I have a 40-year-old person who all they really want to do is, be able to lift weights, kind of train at the gym, they tore their ACL skiing or something like that. They don't want to do that anymore. They really just want to be able to walk, train, be healthy, things like that. Is that someone that absolutely requires their ACL to be reconstructed? I would say, well, maybe not. We have good evidence that people can cope without an ACL, particularly if what they're looking to return to may not be kind of like that level one sporting activity where there's high demands of, cutting and things like that, where having an ACL is a good thing to have because that's what we want, right? We need to make sure we have that there. That's a different discussion than someone who is, maybe a college athlete. They're in a level one sporting activity where they have to be able to cut and change direction. In some cases, people like that, there are copers that do fine without having the ACL reconstructed. But I would say if we're framing it from a probability standpoint, I would think it's more likely that that person would be in need of having the reconstruction done versus the 40-year-old person who really just kind of wants to walk, be able to go up and down stairs, and in resistance train. Does that make sense?
Mm-hmm. Yeah. And for that, I want to take you to sort of a different question, more around what we usually see, also normally from doctors and some physical therapists, and usually these clinicians don't have a strength training background themselves. I wanted to talk to you about when clinicians tell their patients not to strength train anymore. I think a good example of it is when someone has a herniated disc or anything like that. Normally, there's some sort of uh, scaring tactic, you can say, from the doctor telling him he shouldn't lift anymore, and if he was in his shoes, he would never touch a barbell again. But yet again, we see time and time again people just go back to their sport and even come back stronger from that. So what I wanted to ask you is if you had any experience where you had to tell a client of yours or a patient of yours that they can't train anymore.
No, I've not. To me, I have never, been in a situation where I told this person that, given your state, this is something that you shouldn't do anymore. I think as a clinician and as a medical provider, I think that if you're finding yourself in that situation a lot where you are sort of giving out that line of reasoning, I would probably encourage you to kind of reconsider that, because to place limits on a person, especially with something, to kind of use your example with like a, herniation or whatever, that they can no longer lift weights. I think that's absurd. There's no reason to place that sort of hard stop on limitations for something like that. So I can't say that I've had that. I've had patients with low back injuries where they did get that sort of thought put into their head, and that's a situation where it's really unfortunate, because people are left with the impression that they can't go back to something that is meaningful to them. And as a clinician, if you are providing narratives like that, I would encourage you to kind of reevaluate that thought process, because I think it is much more harmful than beneficial.
Mm-hmm. Uh, I can even give myself as an example. I tore my labrum in my shoulder, and when I got into surgery, the doctor told me that I couldn't go back to either kickboxing, jiu-jitsu, or even just basic strength training. And I think it's been 5 years. And since then, I've started weightlifting. I got back to Muay Thai. Everything just went back to normal. Uh, do you have an idea on why my clinicians decide for their patients that they shouldn't do certain things? Is it because they don't trust the actual patient to do it properly or to do it smart, or that they just don't have any experience in that field?
It's probably a combination of things. I think part of it may be, the clinician may be a little bit risk averse, let's say. But to me, I think if you have an understanding of, okay, let's take your shoulder, for example. Okay, so you had a labral repair, right? Okay, so we had a labral repair. What do you want to get back to? It's then my job to kind of intervene in a way that maximizes your ability or your chance to get back to doing those things. So I don't really know why or what the thought process is as to why people put those limitations on individuals. I don't really understand that. It could be something to where this was the inciting event, and the person, it's probably just a path of least resistance, right? We're like, oh, well, just don't do that anymore. But that's not for me to decide. You're right. Like, I'm there, the care needs to be patient centered. And if you say that you want to get back to something like that, then the onus is on me to, try to kind of build that path or guide that path to get you back to those things. Like, I should not be in the position to tell you, what your movement limitations are in something like that. I think this is poor care, because if you want to get back to that, I'm not in the position to tell you what you can or cannot do. I'm here to kind of be on your team and guide that path for you to, okay, you want to get back to Muay Thai? All right, so maybe we have a constraint here with the surgery, but tissues heal, and now it's maybe we're going to work around that constraint for the time being, and then ultimately get you back to that point right there. I think it's my job as a clinician to get you back to what you want to be able to do. It seems, who am I to tell you what you can and cannot, I guess is the easiest way to say that.
I definitely agree with you. Though when you say who are you to tell someone that what they can or cannot do, at the end of the day, you're the professional that they're supposed to trust. So I'm assuming that if you tell them they can definitely go back to an activity that endangers them in the given situation, the sort of fault, you can say, is coming back to you, since you you didn't limit them from being in that situation in the first place.
Yeah, I think that's where like kind of like the clinician being a little bit risk averse is what that comes down to, right? That's not to say that obviously like if you had some sort of repair or surgery done, understanding that for the time being, like, yeah, there's certain things that are going to be off limits for us, right? Maybe at the end of the rehabilitation process, we have a discussion where like, look, is there a potential risk that something like this happens again? Yes, but it really comes down to, how much risk are you comfortable accepting with that? And I think when we think about rehabilitation and let's say, discharge criteria or whatever it may be, my goal is to try and mitigate that risk or decrease the risk of a negative outcome happening as much as possible. And if we get to the point where, how was the best way to kind of phrase this? So like discharge criteria, right? So if the goal is to reduce the likelihood that there's going to be some sort of negative outcome, if the goal is to return to a very low grade task, there's less likelihood of a negative outcome, right? If it's something that's higher level, there may be a little bit more risk that the patient is accepting, but it's still my job to try and prepare them to the best of my ability to get them back to that terminal task if that's what they're up to, right? So it does become a little bit of a discussion of, are you maybe assuming a little bit more risk going back to that sporting or whatever it may be? Sure. But if you're comfortable with that and you understand that, then I am in the position where it is my job to try and prepare you to the best of my ability to be able to do that.
Okay. I definitely agree with you on that. And do you think that the risk of injury or any negative outcome of sort, even being pain, regardless of tissue damage, could be a cause of that exact process of the clinician telling the patient that he can do something, and he goes back to that activity, but that thought is always in his mind that he's going to get injured, he's going to get injured, he's going to experience pain or any sort of discomfort. Do you think that's something of a major component to it?
Certainly can be a factor, I think, right? So like if somebody tells you, like if someone tells you like, if you go back to this, you're going to get hurt, right? There's a certain amount where like that may linger in the person's head, right? Like he told me not to do that because I'm going to hurt myself. So I think that can absolutely be a factor. That's why I think it's important to provide as much certainty as you can, but to state with, in absolute terms that if you do this again, you will get hurt. It's a bridge too far, if that makes sense, right? Because I don't know that necessarily. Like if we go throughout the rehabilitation process, we're hitting all the benchmarks that we feel like we need to or are important to return you back to that. We're being mindful of tissue healing timelines, whatever it may be, key performance indicators that we think are important to track and build up to return you to that task. If we're hitting all those things, and be like, it comes down to a discussion between the clinician and the client and being like, look, I think, where we currently are, we see that we're hitting all the things that we think we need to be hitting to prepare you to go back to the sporting activity or whatever it may be. Is there a potential that something happens where you get injured again? Absolutely, because there's inherent risk in everything that we do. But I think to say it with certainty that if you go back, you're going to get hurt again is not a good way to approach patient interaction and discharge.
Hmm. And I want to expand upon the point that you said that there's risk in everything. I think that in that situations, that's how sort of myths are in this field are setting out. When we're sort of looking for meaning from the professional that we're advised by, when he's telling us that something is definitely going to happen, whether it be an injury or anything else, and it actually happens, but it's just a part of life, since you risk getting injured even with when you cross the road. So when you get injured, you sort of tie that into the definite claim that that same clinician told you, and from then it just becomes quote unquote the truth.
Yeah. I I think you're right on, man. Right. So I think that's why being able to embrace a lot of the complexity and the uncertainty with things that we deal with is important, right? Because making it known that there's an infinite amount of factors that go into an injury, right? And I think provided that you are being honest and upfront with your patient or your client or whoever it may be, being like, look, we're controlling all the things that we can. That does not mean that you are there's no possibility of a negative outcome, right? Or it comes down to this discussion of how do we really know that the things that we're utilizing or we say are putting this person at risk are really the true causal piece of it, right? And I don't think you can know that. All we can really do is kind of establish things and develop abilities or qualities that we think can sort of reduce risk to the highest degree, and then from that point forward it's kind of more of managing risk. So I think we should be cautious in claiming with certainty that the things we're seeing are the true reasons why a negative outcome may occur, because I don't think it's possible to know that. So that's kind of where I would stand on that right there. Like, is it a factor? Yes. Is this the reason why it happened? I don't think we'll ever be in a position where we can say that with any sort of certainty.
Hmm. And starting out, uh, hold on, let me gather my thoughts again. Uh, Sort of, hold on. Okay. I wanted to start getting into some closing thoughts regarding the subject that we talked about, and I wanted to ask you, what do you think we can do to move forward from this? Is there a change that needs to be done, educating either clinicians, coaches, or anything like that, to prevent things like that from happening, whether it being increased risk of negative outcome, we'll call it, and whether it being less people enjoying the benefits of training, whether it being psychological or physical.
Yeah, I think so. Having an understanding that training is important for general health is probably the first one to go with, right? So I wish that more people um, had an understanding of the benefits and the positive things associated with training is probably a good place to start. I wish that more people kind of understood that. That's across the board, right? So that's probably the first place that I would go, is just kind of educating yourself into the benefits of training is probably the first thing that we would go to. And I think that the better understanding that someone has of that, the less likely they are to kind of take those hard stance positions if you go back to this, you're going to hurt yourself or something like that. So that's probably the first place that I would go, is just kind of taking the onus on yourself to kind of educate and understand why these things are beneficial and the positive impact that they can have.
Hmm. But obviously, you can't always trust people who just finished a degree or any sort of education that they might have, and they don't try to expand upon that specific field from that point on, or that they just don't expand upon the sort of, not the same field, but you can say in the same alleyway. If we're talking about injury and strength training, obviously, not all injuries are from strength training or anything like that. You can just walk around the street and have a brick fall on your foot, and you go to the physical therapist, or you can be a sprinter that got injured and tore his ACL, and obviously both will supposed to have different uh, rehabilitation processes, but if someone doesn't have the proper experience for that marathon runner or sprinter, obviously they probably won't be able to give them the proper uh, progression for their field and for what they want to do moving forward.
Yeah, so I think in that instance right there, it's important to have self-awareness as a clinician or as a provider, and understand, am I the best person for the job here? That's not to say that you can't, see them throughout, the early, let's take the sprinter or something like that. If you're dealing with an athlete or a person whose terminal task or end goal you feel like is beyond your scope of knowledge and expertise or understanding, then I think it's your responsibility as a provider to recognize that, to kind of have the humility to say that, look, I can kind of, get you through these early phases here with some of the things that we're dealing with right there, but I don't think that I'm the most equipped person to truly help you to the degree that you're needed and do the service to you that you should have to get you back to that terminal task. So as a provider, I think the onus is then on you to recognize maybe your own limitations in knowledge and understanding or skill set, and not be afraid to either collaborate or send them to someone else who is maybe a better fit for getting them back to the things that they're wanting to get back to, or their desired tasks. That's the point that I would make right there. Not every person that comes through your door is going to be someone that falls under your sort of umbrella of practice or skills to where you're able to help them to the degree that you can. And ultimately, it needs to come down to care has to remain patient-centered. And if you're dealing with someone who you feel like you don't have the ability to do justice to, whether that's in rehabilitation or training or whatever it may be, I think you can't be afraid to send them on to someone else who does have that skill set or ability, because it's ultimately
Mm-hmm.
about them. It's not about me as a clinician or as a coach or anything like that.
Yeah, I agree with you there, though I think that we will run into two major problems, one of which being ego, obviously.
Mm-hmm.
Uh, I think that we're all going to have a hard time at first telling ourselves that we're not either good enough for the job or just fit for the job, because our focus is on something else. But I also think that to know that you lack the knowledge to help that person, you also have to have the knowledge that something like that can be done, something like that does exist. There, you can turn to someone else that can help them reach that certain point that they're looking for. And if you don't have that, you're just stuck in some sort of a bubble that you can't really burst through.
Right.
So I think that expanding upon your knowledge is something that's important, regardless whether you want to act upon it uh, or not.
Yeah, absolutely. And I would say, like, from a patient or a client perspective, don't be afraid to ask your provider or your coach questions, right? Like, it
Mhm.
should be, it's a collaboration, right? Whether it's training or whether it's rehabilitation, there should be input from both sides right there. So don't feel like you're in this position as a clinic, as a patient or as a client, to where you don't have, I would say, if you're in a position where you feel like you're not able to ask questions or kind of get a better understanding of the thought process or the reasoning, and that person isn't able to provide you with the answers, um, maybe that's an indication that, like, well, maybe I need to start to look elsewhere. But I think you should be able to ask whether it's your therapist or your coach or your trainer, you should be able to ask them questions, and they should be receptive to those questions. And if they're not, maybe it's not the best fit. Does that make sense?
Yeah, yeah, I agree with you. And I also think that other than giving you a straight up answer, they should know enough about the field to explain it in the most simplistic way possible. One of the best things that I've heard from a friend of mine is when I was learning physics, and he was telling me that you definitely know that you know the subject when you can explain it to a 5-year-old in
Yeah.
his own language. So I think that a lot of professionals sort of rely on other people not knowing the exact terminology, the professional terminology, and sort of abusing it to justify certain things that otherwise they wouldn't be able to.
Yeah, absolutely. And that's not to say that they should have every answer, right? They should be able to say,
Definitely.
like, I don't know that answer. I'm happy to look into that for you, and I'll try to come up with I'll do some research into that and try to figure that out. And if I can't, well, then maybe, let me send you to this person, or let me put you in contact with this person. They seem to have a better grasp or understanding of that specific subject matter. So I think that's a key quality in people too, is the understanding that, I don't know everything. I'll do my best to find the answer for you if I can, and if I can't, then I will try to find a person who will be able to supply that to you.
Hmm. Okay. I don't want to take too much of your 4th of July time. So I think we'll wrap this up. Uh, is there anything that you want to say as sort of a closing thought, or maybe to talk about any upcoming projects you have, anything about the Journal Club or any of your work?
No, man, I want to say thanks for having me on, man. This was a blast. Hopefully I didn't make too
Thank
much
you.
of an ass out of myself. Was able to answer at least some of your questions. Um,
Uh,
no, so I think, just in regards to, finding clinicians that, specifically from like a training perspective, that you feel like have an understanding of what the demands of athletes are. I think Clinical Athletes a great place to start. They have a network of providers there that you'll be able to find. They're all around the globe, I think, and that's where I would direct people, because they have it's a network of clinicians and providers, many of which are much more knowledgeable than myself. So it's a good place to go if you have some of the similar questions that we were kind of discussing today.
Yeah. And as I said when we were just started talking, that I had experience talking to some of the clinical athlete providers you speak of, being whether being John Flagg or
Yeah,
Quinn or Frank. I can definitely vouch for that, that they know what they're talking about.
absolutely.
All right. So thanks a lot. I really appreciate your time,
Yeah, absolutely.
and
Stay safe out
hope
there.
you have fun. You too.
Bye bye.
See ya.